Welcome to another edition of the Inspired Stories podcast, where leaders share their experiences so we can learn from their successes and be inspired by how they've overcome adversity. My name is Anthony Codispoti, and today's guest is Dr. Barbara J. Brown. Barbara is a licensed clinical community psychologist who has been practicing for over 3 decades and is the founder, CEO of Capitol Hill Consortium for Counseling and Consultation, otherwise known as CCCC. This large private group mental health practice in the greater Washington, D.C. region is celebrating its 15th year and employs over 80 staff that have served thousands of children, adolescents, and adults through the years. Dr. Brown has received both local and national recognition for her company's contributions to the community. CCCC, which can be found at cccmentalhealth.com, was founded in 2009 as a mental health group private practice dedicated to providing high-quality, accessible, and culturally responsive psychotherapy, psychological assessment, and testing for children, adolescents, and adults. They also provide training for pre- and post-doctoral psychologists, including an American Psychological Association accredited internship, a new clinical and community professional development program for early career social work, counseling, and marriage and family counselors launched in fall 2023 with the ambition of becoming a national model for clinical and community-focused mental health practice. Now, before we get into all that good stuff, today's episode is brought to you by my company, Add Back Benefits Agency, where we offer very specific and unique employee benefits that are both great for your team and fiscally optimized for your bottom line. One recent client was able to add over $900 per employee per year in extra cash flow by implementing one of our innovative programs. Results vary for each company, and some organizations may not be eligible. To find out if your company qualifies, contact us today at addbackbenefitsagency.com. Now back to our guest today, the founder of Quad C, Dr. Barbara Brown. I appreciate making the time to share your story today.
Thank you. Thank you for having me today.
So Barbara, tell us what first drew you to the field of behavioral health?
Oh, that was fortunate. In my high school, I was provided an opportunity to take psychology, and my professor was both a minister and taught us psychology. And so I really was introduced to it through a spiritual component, but also a way of healing people. So learned about Jungian dream psychology and primal scream therapy, and I was hooked in terms of just, being fascinated by studying human behavior.
And so from there, what inspired you to first start your own practice?
So I had never planned to start my own practice. I really, when I went to Boston University for my grad school in clinical and community psychology, I intended to just, serve the community. So I started running, being a psychologist as well as being an administrator for various programs that were based in the community, hospital, outpatient treatment programs, government clinic as well. And so the reason, and universities, I worked at universities, so I had a lot of different kinds of experiences, but it was really the fact that there were glass ceilings there for a Black woman, as well as just the bureaucracy, the level of bureaucracy that led me to start my own practice.
And how has that evolved over the years? I mean, you started probably was it a one-woman show? Did you?
Yeah, I started a solo practice. I had a mentor who was very good, Dr. Joyce Berry, who was excellent and really taught me the business of private practice that they don't tell you about in school. And so I built my private practice successfully. And then I decided to join with some partners, and we had a psychiatry component, a psychoeducational component, and psychology. And we started a group practice, Family Assistance in Coping with Trauma and Stress, that lasted 11 years. And my partners grew wary of having a private practice and the struggles of it. And so they departed, still good friends and colleagues. But I decided to then shift to Capitol Hill Consortium for Counseling and Consultation, because we had a small number of, we had about 8 clinicians working for us then. And really, I wanted to make sure that it became a group practice that everyone could basically join and own their portion of, could show their expertise. So that's why the term consortium, of really coming together of like-minded people. We developed our our mission statement, and really started attracting, people who were like-minded in the area of working to provide services regardless of ability to pay. And so we took public and private insurances and just really had a wide swath of people, age, I always joke and say age 3 to 83. And, providing all sorts of services in terms of psychotherapy for individuals, groups, families, couples. And then the psychological testing spans the variety of psychoeducational testing, personality assessment, neuropsych assessment, cognitive assessment, and intelligence testing. So we have all of that.
And so, how do most people find their way to you? Are they finding you online, or they have to come through like a primary care physician for a referral?
Things have evolved over the years because we've just become very well known by all sorts of practices. So we get a lot of our patients, our clients, from our current clients. They refer their family and friends. We get a lot from insurance companies. We get a lot from doctors, physical doctors in the area, hospital settings. We are pretty well known at this point.
What are some of the most common conditions that are presenting themselves?
So the garden variety, anxiety and depression, and stress management. But I think we also are well known for our trauma work, and that can range from emotional neglect to physical and sexual abuse. And we do have some veterans that also who come back and need help for post-traumatic stress disorder.
What are you finding are some of the more effective types of treatment for whether it's PTSD or other types of trauma, neglect, physical abuse?
So I personally have a psychoanalytic, psychodynamic background, and so I blend that with cultural features. And we're an integrative setting, so we have cognitive behavioral therapy. We have the range. So, but for trauma in particular, what we do, I think that's different from other agencies is we do evidence-based work, but we will go into the root. We really try to get to the root of the core issue, and that takes time. And so I tend to have a phase-specific kind of treatment. I'll do an initial assessment and find out basically, not only what happened, but also a lot about any patterns that are recurring in the person's life that are indicative of attachment issues that may have happened, that often happen because of the trauma with other people. I assess for ego strength to see how well people can tolerate going in and dealing with the trauma directly. And usually I find that people need better coping skills. And so before we go deep. And so we have a dialectical behavior treatment that we also do to help with coping skills. And so that's often mixed with the supportive psychotherapy, getting to know the client, building a trusting relationship, helping them with coping skills. And then we can go further into the trauma in terms of the impact that it had on the individual. You don't always need to discuss all of the trauma, but it is important to discuss the effects of the trauma, and especially on the person's sense of self. And from that, and helping people understand that this is something that happened to them, it is not them. It helps them get that distance so they can see that and go through the grieving in some way of the self that was lost because of the trauma, and then starting to rebuild a sense of self in a different way, apart from the trauma. The trauma happened, but at the end of therapy, you want people to be able to put it on whatever shelf they want, that they have control of it. It doesn't have control over them. And from that, they're free to then start building their life in a new way.
A couple of things I want to go into a little bit deeper there. What does it look like when you assess for ego strength? Is it sort of a series of multiple choice questions you're taking people through? Is it sort of more of like a gut feel that you get from being in somebody's presence?
Well, again, having a psychoanalytic background, I'm always looking for defenses that people use. And so I find that when we get closer to discussing what happened, people will do all sorts of things to defend themselves from it. Some people will use denial initially, and sometimes you don't hear about the trauma until months after a person starts treatment, because they've tried to block it out. Other people use humor. It's like they're telling you a story, and they'll use humor as if it's as a deflection of some of the true feelings. Um, Other people have more serious, defenses. And I've worked with people with dissociative personality disorders, and all sorts of coping mechanisms.
So I've heard stories before, and I'm kind of curious to know how common this is that somebody experiences rather significant trauma and then completely blocks out that it had happened until something triggers later in life that brings this sort of back to the surface. Is this more like TV and movie kind of scripts, or is this like a real thing that happens somewhat commonly?
It's a common reaction because, people are trying to survive. And again, taking them to thriving is a different story. So they will, I see it a lot in rape victims, that, it will just be shut down, and really won't come out until much, much later. And it will be triggered by, a date, or a person, or, you know, any association
Just
could happen.
something that who knows how in the brain it sort of sparked a connection that causes them
Right.
to sort of re-remember this.
Right. But then they often try to suppress it again.
Yeah.
The goal of any defense is repression. We don't, that doesn't happen. It's somewhere. It's somewhere. It's coming out in some way, front way or sideways. And often, again, it's affecting people's relationships with one another.
Mm. You made the point that they don't always have to face all the trauma. What do you mean by that?
I mean that we don't have to get into all the details of the trauma. We need to know who was the perpetrator, um, and come to terms with who the perpetrator was. The closer the perpetrator, the more complicated the relationships are. So, stranger anxiety is easier, or stranger perpetration is in a lot of ways easier to deal with than someone you know and you're
Mm-hmm.
connected with,
Mm-hmm.
especially in the family.
Yeah. Then you said sort of, as you're kind of taking them through this process, at some point you get to the point where it's time to work on rebuilding the sense of self.
Hmm.
What does that process kind of look like?
So, first, it starts with a lot of compassion for the self, in terms of, and there are many techniques to kind of separate the what is commonly called the inner child, the younger self that was hurt, from the self that is starting to be able to be a caregiver of that part of you. And so viewing that person, that self, with compassion, as opposed to what often has happened is they've condemned, like it's somehow the victim's fault, somehow their fault. And so after you shift that to it's something that was done to you, then rebuilding first again, um, it's really helping that self come along and be reparented by yourself. So they're no longer they're not viewed negatively. They're helped. You have to take them wherever they were hurt, and then help them come back to the present and reshape relationships. So lots of trust building first in your own self, trusting yourself, and then gradually trusting others. A lot of the clients that I work with go from individual therapy with me, and then they go into group therapy.
Okay. That's sort of like a graduation process.
Right. Yeah.
So are you still practicing quite a bit? I mean, with over
Actually,
80 clinicians, like it
yes.
seems like you've got a
Actually,
lot of
no, I
management.
have replaced myself.
Okay.
When I said that, I said, oh, I'm not doing this, so much anymore. I do supervise people,
Yeah.
but no, I'm not in the day to day. I had to step away actually right after the pandemic, or during the pandemic in some ways, to start taking care of the business. That one of the questions that you have for me is about difficulties in the pandemic really, really, really changed the business. So I
Let's hear
had
more about that then.
to sure. So, you know, the first thing was just like we were 100% in person.
Mhm.
And in the space of a weekend, we had been talking about telehealth, but we had not planned anything, any time frame. But when I think it was March 18th came, we, basically said we've got to do something else. So we went from 100% in person to 100% remote in a weekend, and without even losing any clients,
Wow.
clinicians, just setting it all up to succeed. And that's with about 1,000 clients a week.
Wow.
Yeah. It was
Just at
really
the flip of a
exciting.
switch, you had to do it. And
We
so
had to do it.
was there
It's
a
just like how.
platform that you guys could go to? Were you just using Zoom, or like how
No,
did you
well,
make it
no,
happen so fast?
we hadn't even started with that. We had been looking at platforms, and so we chose a platform. I think we were with Valent at that point, but we had to do. Were not integrated. We had Zoom separate. We had billing separate. We had all of that. Now we've integrated all of that, but at the time it was just like, what can we do quickly? And
Now,
HIPAA compliant in HIPAA compliant way, and getting all the clients to sign this new telehealth form.
yeah.
So
Now, a lot of businesses that I talked to as they went through the pandemic, there were times where they're like, I don't know if my business is going to survive. I'm going to guess that wasn't the case
no, we
for you. You
grew.
were overloaded, right?
Yeah, we grew. We grew, I think, 3 or 4 times larger. I mean, it was just amazing. And I kept hiring clinicians, and we were all remote, and for that 2-year period. So
And
it
how
really
were you
did.
finding clinicians?
They were finding us. I mean, we always advertise, but people resonate with the mission, and to be able to give back to everybody, and to really make mental health accessible. And as you can imagine, a lot of people were really hurting during the pandemic.
Yeah.
Especially, we did a lot of work with frontline people too, the
Mm,
physicians, especially. They were having such a hard time. It was such a scary time for them.
yeah. I'm kind of curious, as somebody who had a front row seat to sort of mental health picture pre-COVID, during COVID, and now that, we've kind of come out of that, what what sort of, how would you sort of describe the trajectory, the curve, if you were to kind of describe it in a big picture term?
Um, I think it really depended on your ability to adapt to different circumstances. And some people adapted pretty well and took advantage of it, and some people adapted very poorly, or they didn't adapt. And, the mental health crisis, as you know, got so much worse. With young people, a lot of anxiety, just uh, anxiety on its deepest level. It's not having control.
Hmm.
And none of us really had control over that period of time. And so you just had to, as I said, adapt or be anxious a lot,
Hmm.
depressed, isolated, people who were in relationships during that period of time that were positive, you know, got a lot out of that time together. People who were having difficulties or ran into difficulties, there were a lot of breakups during that period of time.
Yeah.
We don't know, I don't know the extent of domestic violence that was occurring without any outlets. People, if kids were not going to school, people weren't going to work, what were the outlets? So I would imagine a lot of negative things happened as well that we
N-
don't even know about.
Now that we're on the other side, for the
Yeah.
most part, what are you seeing? Is there a recovery? Are people still struggling? What?
I think people are recovering. I know that a lot of mental health programs started as a result, a lot of funding started coming into mental health as a result. We are in the school system now. That was one of the grants that we got after the pandemic to help the kids, and kids need help. But the suicide rate. I had never seen kids that young. I mean, very young, be very serious about suicide. They're just the loss of hope, the loss of you know wherewithal to keep going. So a
How
lot of
young are we
anxiety, a
talking?
lot of depression. I saw kids as young as 6, and before the pandemic, um, there were some kids who were talking about it, but they weren't serious. These kids were serious. Yeah. So the need for family support is also great. I always think that I have always thought, since I was a sociology and psychology major at Wellesley, that the family has got such a burden on it to carry forth all these things for the human condition, and it's too much. We don't have enough support, I don't think, in the United States. But when families became isolated like that, and it was a matter of who had resources and who didn't, it just got much worse.
Yeah.
And if the adults can't support the children can't support themselves. It's really, they try, but it takes a toll. Always takes a toll because they're not allowed to be kids.
There was a lot of debate going through COVID about, should we isolate? Should we not isolate? Should we mask? Should we social distance? Should we come back together? And early on, I was a big proponent of, man, let's lock down, let's mask, let's separate, let's do as much as we can to prevent death. Having now come through and hearing stories like yours, as well as many others, I think the big part that I discounted was the mental and emotional suffering that would come from being isolated like that. For me, it was just, hey, if we can just stay apart long enough, we'll get some vaccines. Like we'll make it through this. Because once somebody passes away, there's no undoing that. There's no bringing them back.
Right.
But the part that I so heavily discounted was this component of human suffering that went with being, physically disconnected from each other.
I think we all did. It was just, how do you stay safe during this very scary period, and with people dying at such high rates? It's like, I'd rather stay home.
Right.
So
How has your mission evolved sort of through COVID and post COVID?
I think we're just really trying to find resources, more and more resources to bring to people. And insurance, again, taking insurance isn't always the easiest path. A lot of businesses, psychologists, therapists in general, went into self pay practices because of some of the issues with insurances. Um, Managed care. I always say I started the field and I had my first private practice in the 80s before managed care existed. And so just seeing it now and how it's evolving and how much control people who are not the therapists or are not the providers have over our practice is just not the best.
Sort of, right. People who aren't trained and aren't seeing the patients are making decisions on what level of care they should have access to.
And yes,
Yeah. Yeah.
yeah.
It's a challenging situation for sure. Are are there, I mean, you talk about being able to accept, people across different abilities to pay. Are there, do you take donations? Is there like a nonprofit component to this so you can serve people who,
Well, so most people can get Medicaid, or if they can't get that, they can get the public, the commercial insurances through their work and through the healthcare, like we use DC Health Link. The Affordable Care Act allows that. So we mainly go through that. There is a low fee component if people can't pay. We can have a sliding scale. I tend to come from the point of view that people should, in order to be accountable for the value of the work, if they're not paying Medicaid, then you need to show up to your meetings. But if you can pay, then even a small amount is important for people to value it.
right? You've grown to what, 80 clinicians now? Over 80 clinicians?
Yeah, we
Yeah.
have we have 80 clinicians, and including our trainees. So
And we just touched on already how your role has sort of changed. You're not practicing like you used to. Do you miss that? Has that been a difficult transition for you?
I think that it was, I mean, after doing it as long as I've done it, I think that it was okay to transition. I still have lots of experience to rely on, but I keep in touch with it through the training. I am now the director of training in addition to being the CEO. And so I meet regularly with all of the trainees and students that we have. And I love it because that's like my new passion is to help the next generation take over. So,
So we touched on telehealth a little bit, and you went from 100% in person to 100% remote.
and
Now I'm
now
going to guess, what was that? Now
now
you're
we're
hybrid.
hybrid, right?
Yeah. So what percentage is in person versus remote? And what are the sort of the differences that you see between being able to deliver the care remotely versus in person?
So we're about 25% in person now. I would say 75% remote. And that's in large part because the clinicians prefer it, but also the clients have adapted to it and really, really like it. We found that our no show rate went way down with telehealth. And people could make it on time and stay the whole time. Going back to work, even there's more flexibility from their jobs and being able to in do both in person as well as remote work, during their lunch breaks. So it's really helped. I think therapists were surprised that we were the more resistant ones to starting telehealth. But once we started it, we love it. You can do a lot more um, A lot more than you think in terms of reading nonverbals, reading, being in interaction just like we are today. You can tell how someone's feeling. You can tell all of that. I do think it's more difficult with children. It's hard to, there are some more and more play therapy techniques that you can do online that are digital, um, but allow some of the same thing that you can get in person where it's more interactive. But I still, that and psychological testing again, uh, the field has adapted to the need. And so there are testing things that you can do that have manipulatives that you can use online as well. But by and large, we still prefer the play therapy in person and the testing in person.
I'm going to guess, especially in a heavily congested area like the DC area where you guys are, that not having to drive across town or fight traffic is probably a big reason that both clinicians as well as patients are taking to this, and a big reason why the no-show rate has dropped.
Yes, and the payment for parking and all of that
Mhm.
that goes along with the commute. So it is much easier.
So are you able to employ clinicians who live in different parts of the country then? Does that give you sort of more flexibility in hiring?
It does, but we try to do that very carefully. It's because, again, the one thing about being in a remote world is trying to connect. And we do find that when we do have in person, get togethers, there's a different feel to it than just seeing each other on Zoom. So we prefer to have people that we know. But having said that, we've had clinicians who have been with us and then have moved to other locations, and we feel very comfortable with employing them because we know them. And if someone has been recommended to us by one of our clinicians, then that helps. But otherwise, it's really screening and just really having at least 3 interviews and really making sure there's a good connection and that our values are the same and our practices are, just again excellent and ethical and life changing.
Barbara, how do you ensure that across such a big workforce that is geographically spread out? I mean, even for, most of the folks I get are still kind of in the same physical region, but you're not in person together, all of you, all the time. I would imagine that presents some challenges.
Yeah, it certainly does, especially in terms of people feeling really connected. But we do have several things in place. Again, we have supervision for people who are not yet fully licensed, so licensed graduate workers, or again, our pre-doctoral or postdoctoral trainees. But then we also have peer consultation and peer groups that are I would love everyone to be in them, but not everyone has the time. But we know we can contact each other as needed for consultation, and especially on issues where there's liability. You want to have a second opinion. We also have a unique thing called challenging case presentations. And so twice a month, anyone can come and present a case that they're having a challenge with, and we'll discuss it as a group.
Mhm. Your team has been described as experienced, multicultural, multidisciplinary. Why is the diversity component so important in providing effective mental health services?
I think we want to be representative of our society for a few reasons. I also think we're good role models for other practices in terms of really looking at diversity as a strength. But also we have a lot of variety in terms of who people can relate to. And so because I started the company, we have a lot of people coming and asking for a Black female therapist. Um, some of our male therapists don't get it filled at the same rate as the female therapists, because even men, and this has been throughout my career, often men, when they're coming in this vulnerability,
Oh.
they want to see women as opposed to men. But we value our men in our practice very much. And even though there are fewer of them than there used to be when I started, women were the minority instead of the majority
Mm.
when I started in practice, but now it's the reverse.
I mean, yeah, you talked about in the beginning of the interview sort of the glass ceiling that you were running into. I'm going to
Hmm.
guess some combination of, being African American, some combination of being a woman. Um, have you seen both of those sort of glass ceilings kind of disintegrate, or do you
No,
think there's still very much that no?
I didn't know.
Too Pollyanna, not we're
Yeah,
not there yet, huh? Okay.
no. I will tell a story of we had, because our practice had been very successful in keeping people out of the hospital who had a lot of complex trauma. We were on the preferred list for as providers, one of two in DC at that point. Anyway, we were asked to join a group, and I think it was myself and maybe one other female, and of this large group, and everyone else were males, white males. And when I was asked to come back to GW to help out, they were having some issues there, and so I went back there, and I had someone else take over the practice for a little bit, even though I was still with the practice, but I was just doing a side thing and helping GW. Anyway, I sent him to the same meeting I had been going to for a year, and he was a white male, and he got invited out to this, you know, old boy network
Wow.
to enhance the practice that I had never been invited to. And I was like,
Nobody ever brought it up even. No.
nope. And I said, huh, this is something.
Yeah.
So no, it exists.
Okay.
And I'm in a lot of female business groups as a result.
Yeah.
Ones that are just strictly for Black women, like the Bow Collective, Black Owners and Women Collective. But I'm in the Women Presidents Organization, Women Elevating Women, just a lot of things where you get validation, you get colleagues who want to help you. So
And these groups that you're a part of, is this more business development, or is this more of sort of engaging with the community? I mean, community empowerment seems to be central to your mission, right?
yes, so a lot of it, some of the groups are both and. Um, in terms of business development is as their primary goal, but I'm like with the one of my newest ones is the Women's Business Collaborative, and I'm in a special group, the Women of Purpose, and so we really want to make a social impact. So it's both and. The Bow Collective, we're working on Black women empowerment in our society and really building that in a financial structure that we don't have enough of. So,
Barbara, I'm curious, are there any new types of therapies or approaches to therapy that you're excited to either continue to follow or maybe use yourself?
yes, I think the frontier that is really in its toddler phase is really neuropsychological, just really brain behavior, really understanding the brain much better. And um, some of the techniques that are newer, like tapping or EMDR, have a neuropsych basis to them, neurobiofeedback, really trying to help the brain do something different. We used to think, very backward, like the brain didn't have plasticity, it didn't
Mm.
have a way of resilience, etc. And now we know that's not true. The brain keeps evolving in that nothing has to be set in stone, even though it can be hardwired. There's still ways, there are approaches that are now
To
being
mold
called
it.
like bottom up approaches to pass the verbal. The verbal is head down. The bottom up approaches are not verbal, but they are effective.
So explain what tapping and EMDR are.
So EMDR is uses the bilateral parts of the brain to help shift people while they're talking about some difficult areas, or they're trying to reinforce positive coping skills. And so bilateral means that you're using, you have the person follow your fingers, or there's other, you can use tapping, or you can use, but you're using both sides of your brain to kind of help um, uh, break up the previously set patterns and
Is it
shift.
sort of like forming new pathways in the brain?
Yes, that's the idea. Is like when the pathways are always there, but when you keep doing the same thing over
Mhm.
and over, that's what you automatically go to. So to shift it, you want to create new pathways.
I've seen some wearable devices that I don't know, neck or head area that will deliver like small like electrical stimulation. Is that kind of in this same field, or is that kind of
I
hokum?
think I don't know which one that's called because there are a bunch of them coming out, but yes, they're trying to get to different parts of the brain. Yeah,
Same kind of idea.
yeah.
Yeah. Barbara, you've been involved in mental health advocacy through different published works and speaking engagements. What are some of the messages that you're most excited to share?
I always like the normalization issue. It's like we all have issues. Um, we believe that the healthiest people have been in therapy, have done therapy either by themselves, because there are these wonderful self help books, or with someone through more guided facilitation. And that the joke is that people are in therapy, because of other people, that they're in touch with. But again, the relationship to self is also critical. So I always want to make sure that people know that it's okay. The whole thing, it's okay not to be okay. Before that existed, it was just really trying to normalize whatever you're going through. Um, we can work through, and it's important to work through. That self-awareness that you have is important, as well as being surrounded by a supportive community that
Are
can
there
help
any
you.
types of treatments, maybe new or experimental, that you've got an eye on? You're like, yeah, that's probably something people should stay away from.
No, I think because we're, you know some things are tried and true, and we know they work. Other things we are experimenting with, and we're testing, we're seeing what the outcomes are. But you have to experiment, because if you don't, you're going to stay the same. And so um, I mentioned primal scream therapy that I was introduced to in high school. No, I don't use that technique,
What
but
is it? I,
basically just releasing. It's
okay.
basically a cathartic release. I think there's lots of ways other than that to do that. But it's I think we have to experiment to keep going, and see what works. We just have to have good handles on it. That's why they have internal review boards for any kind of experimentation for research, so that we make sure that it's ethical and that it doesn't hurt people more than it's helping.
Why did you get away from primal scream therapy?
Um, I don't think it was. I heard it wasn't very effective,
Okay.
and it's too loud. It hurt my ears. So,
Fair enough. Yeah. Plus, if we're doing telehealth now, and I'm in my office taking my telehealth visit, yeah, I don't want to upset my coworkers.
right, right.
Yeah. Um, where do you see the future of the practice going? Quad C, the consortium. What's in store?
I see us expanding. I do am looking I'm looking at diversification in terms of payer types. As we've gotten more contracts, and insurance in some ways is getting more bureaucratic in terms of their oversight. um, I just want to have more options. So, we have self pay components in terms of doing psychoeducational workshops, and we have a series of webinars that we're planning in terms of the training component, contracts in the schools, contracts with the military. I mean, we're open to different kinds of funding. I really, as I said, my passion at this point is really the next generation and developing an army of therapists that are really well trained in clinical and really have the outlook of wanting to help people in the community, not just self pay, but just really being open and finding more and more effective and faster ways to treat people. So.
Is the size of the consortium unusual? I mean, are most mental health practices on the smaller side? Are you a bit of an outlier here?
We are one of the larger practices for sure in the area, and that growth has it's wonderful, but it has created challenges in terms of keeping people, connected. And um, but we do a pretty good job making sure our standard of care is good. We do a lot of outcome pieces with clients to make sure that they're doing okay. They let us know if they're not doing okay, and then we help. And they know that if a therapist is not the right fit for them, that they can change. But they like the flexibility, that they like the choices that we have in the people. And because we were one of the first group private practices in the area, again, we're well known. Um, we've been around for 15 years, tried and true. And so we see ourselves continuing. I do see that, you know, there are a lot of national practices at this point that are growing, and certainly have knocked on my door many times to see if we are interested in selling. Um, I think that, it's not something that I'm looking for, because I'm looking for us to grow. But again, I have not found yet someone with the same value system as we have, that's looking to expand that service. So I think people say that they are committed, but then people will only take certain insurances, et cetera. So um,
That was going to be my follow-up question: is where are the disconnects? Is it primarily in the forms of payment, the insurance that they'll accept?
yes,
Like they don't want to take Medicaid, I'm assuming.
many of them don't take
Yeah.
Medicaid, but some do. Some do, but not the large national ones. And we have to be careful with the bureaucracy in Medicaid, because you don't want to turn off people who really want to help people
Yeah.
by over, you know, bureaucrat, the bureaucracy of it.
Yeah.
Right.
Is there thoughts in your mind of expanding geographically from your base now?
Yeah. Um, Again, we're in the DMV in Virginia, Maryland, and DC. But as I said, some of our providers who we know who are still licensed here have moved. And so there's the possibility of opening up places there as well.
Barbara, you've got a lot of experience in clinical community psychology. Um, I'm kind of curious, from your perspective, have you developed any unique theories or perspectives on people, business, life in general? You know, being able to have helped so many people and now supervising so many people that are helping an even broader range of people. Are there sort of patterns or things that you've kind of identified?
I don't think this is new, but it always amazes me how micro and macro, really are the same thing, whether you're studying an individual, studying, a community, studying a culture, studying, globally. It's human nature does not change. Human nature doesn't change. That's the science of psychology. And so when we're looking at the aggression and the war, and I'm always thinking about who the leaders are and what they're thinking and why they're acting the way they are. And you can see it in a family. You can see it in a person who's warring with themselves. So it's that always amazes me that it's the
The
same.
micro and the macro is the
Yes,
same, whether it's
it
world
is.
leaders who are fighting over a piece of turf or it's an internal family dynamic that there's
Mhm.
friction going on over something.
Yeah, and so I find that fascinating, and I want to write more and more about that if I get a chance. I need the time.
Um, what's something you wish you could teach a younger version of yourself, Doctor?
To go to business school or to go to the Goldman Sachs or one of these things at a much earlier age, because a lot of I didn't go to school to become a businesswoman. I went to school to become a psychologist, and so I've learned by making a lot of mistakes, um, and going into some of the business development groups has really helped. But an earlier version, I would have gone to business school in addition to to the PhD.
You mentioned one mentor in the beginning of our conversation. Is there anybody else, or maybe any books or other podcasts that have been particularly helpful in your personal professional development?
Yeah, when I think of the influences, besides my father, and my family, or physicians, well, like my sister's the fourth generation physician in the family, so a lot of healing, a lot of community work, and then I had social justice people in the family who were um, really good in really focused on civil rights opportunities. And so those were very early influences. But David Satcher, I will say this: when he was the Surgeon General, and what was it in Carter? I think it was when Carter was around. I can't remember exactly, but he influenced me in his saying, there is no health without mental health. And for a physician to say that in on a national level was so significant in terms of validating the role of mental health. And it wasn't popular at that time. He also talked a lot about the lack of resources in the Black community in terms of mental health. And so those two things were really influential on me. I am just such a fan of his. And he has continued his work, I think, down at Morehouse. I think my Hussein Abdullahi Bulhan, who was my first reader for my dissertation which was the first dissertation on um, violence in Black couples in the early 80s. Anyway, he was a huge influence on me. He taught me about the psychology of oppression, basically. He was um, one of the foremost experts on Frantz Fanon. And
What is
so
that?
Frantz Fanon, who was a psychiatrist I think, in Algeria. And so he taught me the psychology of oppression. So really putting that together with these very westernized psychoanalytic concepts and the psychology of oppression, how do you work together to help people free, the individual bonds that they have? How do you free them from those? So those were my biggest influences in my career.
Dr. David Satcher, if Google is to be believed here, was the 16th Surgeon General, served under Clinton from 98 to
Clinton.
2002.
Clinton. Okay.
Yeah. Carter would have been quite a few
Yeah.
years
I was going to
earlier.
say before I started psychology,
Yeah.
right?
I think I was in diapers back then.
Mhm.
Dr. Brown, is there maybe something fun or interesting that we haven't covered about you? Something that maybe most people wouldn't even know about you?
The first thing that came to mind was I've been in the same book club since I moved to DC, basically since '89, and we get together every month and read and talk and gossip and all sorts of good things. But we've been together, and that has been a very special bond that I've had with these. We call ourselves the Seven Sisters. So.
I like that.
Yeah, but there are actually 10 to 20 of us at any given time. But
It's grown beyond the
yeah,
original core. Yeah,
yes,
I get
yes.
it. I get it. One more question for you, Dr. Brown, but before I ask it, I want to do two things. Everyone listening today, I know that you love today's content. Please hit the like, share, subscribe button on your favorite podcast app. I also want to let people know the best way to get in touch with you or with the consortium. What would that be?
Sure. So our main number is 202-544-5440. And again, CCCC at mentalhealth.com is our website. And you can reach us by email at support@cccccmentalhealth.com, or for business purposes, business at cccccmentalhealth.com.
Great.
And, we are reachable.
Yeah. We'll have all that stuff in the show notes if somebody missed it. But last question for you. How do you see the mental health care space evolving in the next couple of years? What do you think maybe some of the biggest changes that are coming?
Technology.
Okay.
Technology is it's already starting. It's just helping physicians and therapists do what we do faster. I think it will help us in our compliance with all of the bureaucracy that is coming, the value-based care models. It will help us so that we can stay focused on our clinical work and helping people. There are going to be virtual agents. There are going to be lots of things coming soon. And so I can't predict it all, but I just know that AI is going to change the game and help people scale, help people have access, help people save time, be more efficient in our operations. So technology for sure.
Do you see the AI bots as a threat to what you and your colleagues are doing? Do you see it as just a way? I mean, if an AI bot could do some percentage of what you and your staff do, does that feel like a threat? Does that risk
No,
replacing
because well,
somebody?
I don't, not to me, because I do think the human element will always be there. That it's just helping us maybe expand our workforce in the ways that we need to, because there aren't enough therapists for all the needs that there are. And so I don't see humans being separate from what we're going to do with the technology.
Do you see like a human therapist using AI to support the way that they're delivering care, or is it sort of a different level of care? Maybe somebody can't afford a therapist, or they can't get into the schedule or something, and so they meet with the AI tool today. Right? Do you have sort of any
Yeah,
concept of
I
how this might
do.
unfold?
I do. And I have NDAs on some things. So,
Okay, fair enough. Maybe we'll have you back in a couple of years as some of this is unfolded, and you could give us a little peek behind the scenes.
yes, but
Okay.
yeah, there are lots of things happening that I think that will enhance our abilities in the field, and it won't detract from it.
Okay. Well, that's very exciting. Sometimes the mystery of it is more fun of knowing what it actually could be. Well, Dr. Barbara Brown, I want to be the first one to thank you for sharing both your time and your story with us today. I'm really grateful.
Oh, thank you. This was a lot of fun. You were a great host.
I
Thank you.
appreciate your kind words. Folks, that's a wrap on another episode of the Inspired Stories podcast. Thanks for learning with us today.